Okay.
Do you mean my whole stand-up routine wasn't recorded yet?
No.
Oh, do I have to do it again?
Okay.
Save it for the end.
Okay,
Yeah.
or
Put it in-
tomorrow.
Yeah.
Put it in the chat. Okay. Well, without further ado, I'd like to, welcome all of you to our webinar, and I'm so delighted that Dr. Joseph Gottman is with us today. Dr. Gottman is a clinical assistant professor, Department of Neurology at the NYU Grossman School of Medicine. He's on the staff of the NYU Winthrop Hospital, where he spends much of his time treating patients with MS and other autoimmune diseases, as well as dementia. His medical degree is from the University of Connecticut, and he did his residency at the Albert Einstein College of Medicine of Yeshiva University, which was followed by a fellowship at the NYU School of Medicine in multiple sclerosis. Dr. Gottman has always been interested in science, even as a child, and he followed his father, who's a surgeon, into medicine. He said that during his time in medical school, he found the nervous system to be among the most interesting subjects. According to Dr. Gottman, the function of the brain and mind is the core of who we are as human beings, and being able to provide care for this function is one of the most rewarding parts of being a neurologist. So without further ado, I would like to introduce Dr. Joseph Maxwell Guppin.
All right, thank you,
Hello.
Pam, for that lovely introduction. Thank you, all of you, for taking your Friday afternoon to listen to me. I have some slides to go through for a PowerPoint, but I'm also going to leave plenty of time for questions and discussions. I will just sort of give a couple of caveats at the very beginning, with what I'm saying here during this webinar. Obviously I'm trying to, I'll speak about best practices in dementia and in neurology, but inevitably some of what I'm saying will be my own opinion, and, other doctors may have other opinions. So always follow the opinion of the doctor who is treating you or your loved ones. But, and especially as we get into questions about, if anyone has questions about individual cases, I'll obviously do my best to answer, with the caveat that obviously, not knowing the case, you shouldn't take anything I'm saying as definite medical advice. In any case, without further ado, let me try to share my screen. All right, cool. Can everyone see that right now?
Yeah.
Yes.
All right, great. Okay, so just to go through, I seem to have lost control.
You lost control.
Small world.
Let me make sure you're a co-host. Yeah, you're a co-host. Why would you lose control?
All right, okay, there we go. Now I can change slides. I just had to open and close it for a second. You can see the new slide that says
Yeah.
no disclosures. All right, yeah, so I have no disclosures relevant to this. No drug companies are paying me to do this. As I said, these are all my own opinions. So I figured I'd start off with the biggest question, and this is probably the biggest question I get asked when I'm consulting on patients who come to my office with questions about memory and thinking. So what is dementia? And that can be phrased in different ways. Some people ask me, oh, well, do I or does my loved one, do they have Alzheimer's or do they have dementia? Short answer to that is sometimes yes, both. But I figured I'd just start off with sort of giving some definitions so that we all are on the same page about what we're talking about. So dementia, broadly speaking, is a memory or cognitive thinking problem severe enough to interfere with everyday life. And, dementia is a category of illness, and there are specific causes of dementia. So, dementia is like headache. So there are different types of headache. There are migraine headaches and tension type headaches and, headaches from bleeding in the brain, things like that, but headache is the broad category. In that similar way, dementia is sort of the broad category of these memory or cognitive problems interfering with everyday life. Sort of as another term, I want to talk a little bit about mild cognitive impairment, or MCI. What mild cognitive impairment is if there are memory problems greater than we expect for a person based on their age, but not severe enough to interfere with their everyday life. As we get older, all of us start to have some problems with memory, start to have a little bit more trouble remembering names, remembering where we put things around the house. I know it happens to me. I've lost my wallet more times than I'd like to admit. But mild cognitive impairment is greater than you expect for the person's age, but not quite to that point of dementia where it's interfering with their everyday lifestyle activities. So, here's a slide from, this is from the Alzheimer's Association, actually, where I took a few slides. I find some of their information quite useful. So this is just sort of comparing, what are signs of normal aging versus what are signs of dementia. So, someone, as they get older, people make bad decisions once in a while, but if people are consistently having poor judgment, poor decision making, major financial decisions that aren't in line with what you would expect, that could be a sign of dementia. Missing a bill payment now and then could be a typical age-related change. But, if you're truly unable to maintain a budget when previously you were able to do so, that could be dementia. Having a little bit of trouble remembering what day it is, especially in this quarantine situation when we're all at home doing most of our interactions via Zoom, that can be a typical age-related or quarantine-related change. But if you're consistently having trouble remembering the date, remembering what season it is, that could be a sign of dementia. Having trouble remembering what word to use, which I'm sure you'll notice that a few times even in this talk from me, that can be a typical age-related change. But if it's truly to the point where you have difficulty maintaining a conversation or having difficulty making yourself understood, that can be a sign of dementia. And again, as I sort of alluded to, if you sort of misplace things around the house time to time, forgetting where you put forgetting where you put your glasses, things like that, that can be a typical age-related change. But, if you're truly unable to find things, unable to retrace your steps to figure out where you left them, that can be a sign of dementia. So, to sort of speak a little bit more technically about what is dementia, these are the diagnostic criteria for dementia. These are taken from what's called the DSM-5, or the Diagnostic and Statistical Manual, the 5th edition, which sort of encodes the diagnostic criteria for many mental and psychiatric disorders, as well as some neurological disorders. So in order to be diagnosed with dementia, you need to have significant cognitive impairment in at least one of these domains. So learning and memory, language, executive function, meaning things like planning and organization, complex attention, perceptual motor function, meaning, being able to perceive things, understand where things are, especially in relation to one another. And then social cognition, meaning, how you relate to other people, understanding other people's feelings and how what you say might be perceived, things like that. To diagnose dementia, these things must be acquired and represent a significant decline from prior functioning. So, again, this has to be somebody that was functioning at a higher level and is now having impairment. There are unfortunately neurological disorders, neurological situations where people never get that, so never get an understanding of language, never get an understanding of social cognition. That's not dementia. That, is static encephalopathy, something like that. As I alluded to earlier, in order for it to be called dementia, as opposed to just mild cognitive impairment, it has to interfere with independence in everyday activities. The other thing is dementia is not occurring exclusively during delirium. So, this has to be something that's persistent. Anyone, let's say if they're intoxicated, or if, you know, they have a major medical illness, their electrolytes are off, they're in the hospital, they're very sick, their oxygen level is low, their sugars are very low or very high, you know, they can have changes in their thinking and their memory, which is not dementia. And then not better accounted for by another disorder. So, you know, again, I alluded to that a little bit earlier, but again, you know, if somebody has schizophrenia and that's why they can't maintain complex attention or can't, you know, control their executive function, that's not dementia, that's schizophrenia. So, you know, as with most of these diagnostic criteria in the DSM-5, you need to sort of rule out other medical and other psychological conditions to make a diagnosis. So that's sort of broadly speaking about dementia. So, you know, dementia versus Alzheimer's. So, you know, again, as I said, dementia is sort of the general term. So symptoms of decline in memory, reasoning, or other thinking. Alzheimer's is a specific type of dementia, similar to how migraine is a specific type of headache. Alzheimer's is a specific type of dementia, and it's felt to be the most common type of dementia in the older population. You know, and again, there are various types of dementia. I'll talk about some of these in more detail. So Alzheimer's disease is probably the most common, followed by vascular dementia and dementia with Lewy bodies. I'll also touch on Parkinson's disease dementia, frontotemporal dementia, and mixed dementia. There are other types of dementia that are less common that I won't touch on specifically during this talk, although, you know, if anyone has questions about things, they can certainly ask me. So as I said, Alzheimer's disease is the most common type of dementia in older individuals, meaning individuals over the age of 65. You know, about 60 to 80% of dementia in the older population is Alzheimer's. And Alzheimer's is a neurodegenerative disease, meaning it's caused by the breakdown of nerve cells and the connection between those nerve cells. And if you look sort of pathologically, if you cut open a brain, as Dr. Alzheimer did in some of his patients, displaying some of the symptoms we'll talk about, you can see things microscopically. And those are things like neuritic plaques, which are made up of a protein called amyloid beta. You'll hear me talk about that a little bit more later. You can have deposits of amyloid beta that occur outside the nerve cells. And you can have neurofibrillary tangles, which are a collection of a protein called tau that occurs inside the nerve cells and causes dysfunction and death of the nerve cells themselves. Alzheimer's is a disease of older individuals. It's generally very rare before the age of 60. And the prevalence of Alzheimer's doubles about every 5 years over age 65. There are some cases of Alzheimer's that occur at younger ages. Some of those are caused by genetic mutations, including dominant genetic mutations. Again, I'm not gonna speak in too much detail about those because those do tend to be very rare cases of Alzheimer's disease in terms of the true genetically dominant cases. But again, if anyone has any questions, we can talk about that more later. So, you know, just to sort of show everyone, this is from an autopsy study of a patient who passed away with Alzheimer's disease. And this sort of shows some of the things that I was speaking about earlier. So you can see on the right here, you can see sort of outside the cell, you can see a neuritic plaque, which is made up of beta amyloid. And then in the lower left, this dark area here is a neurofibrillary tangle inside the nerve cells. And here's another nerve cell here. You know, I did sort of mention before, Alzheimer's disease tends to be a disease of older individuals. The statistics show 1 in 10 people over the age of 65 has Alzheimer's dementia. And as I mentioned, the risk increases with age, going from about 3% in people between the ages of 65 and 74, up to about 1/3 of people 85 or older. And, you know, 5.8 million Americans are living with Alzheimer's disease, you know, and as I said, uncommon under the age of 65, although there are about 200,000 people under the age of 65 estimated to have Alzheimer's disease. And, this is just a pie chart again, showing sort of the percentages of people by age who have been diagnosed with Alzheimer's disease. Other risk factors for Alzheimer's disease. I did say, true genetic Alzheimer's disease in the sense of inherited Alzheimer's disease, dominant Alzheimer's disease is quite rare. Family history does play a lesser role in other individuals. So people who do have a relative with Alzheimer's disease are at a somewhat higher risk for acquiring Alzheimer's disease. That risk is somewhat age dependent, meaning people who have relatives that get Alzheimer's disease at a younger age are probably at higher risk than people whose relatives got Alzheimer's at an older age. So, whenever someone asks me, do I have Alzheimer's because my mother had Alzheimer's? Well, the difference is, did your mother get Alzheimer's when she was 65 or did she get it when she was 90? Because that plays a big difference in risk. Another thing that we're understanding has a huge risk in terms of Alzheimer's disease risk factor are what we call vascular risk factors, meaning, function of the heart, of the blood vessels, things like that. So conditions like high blood pressure, high cholesterol, diabetes, obesity, these all have a huge role on Alzheimer's disease in particular and on dementia in general. So, if there's sort of one thing that I hope everyone takes home from this, it's that, controlling these vascular risk factors, making sure if you have any of these, that you're seeing your doctor and taking care of them, that you're doing things like regular exercise to prevent these types of problems. That's vitally important, A, in your general health and B, in your brain health. As I tell all of my patients, heart health and body health is brain health. So, controlling those risk factors definitely goes a huge way in terms of modifying the risk. We know another risk for Alzheimer's disease does seem to be a lower educational level. There's a concept called cognitive reserve, which sort of talks about, if people sort of are at a higher educational level, they seem to sort of be more resistant to the risks of Alzheimer's, probably, maybe because they're sort of at a higher level to begin with. I will extend this to also say making sure you're doing things that are cognitively enriching also seems to reduce the risk for Alzheimer's disease and other dementias. So, no matter how old you are, no matter what your educational level is, doing things regularly to keep your mind active is important. And again, it doesn't always need to be a crossword puzzle or a word search. It's finding those things that you enjoy that help to keep your mind active, whether that's painting or learning a language or, hopefully as all of this clears up with the coronavirus, going to a museum, things like that, those are all important things. Other risk factors, head trauma, brain trauma, I'm sure we've all heard the stories about athletes and things like that, especially athletes in contact sports, unfortunately falling victim to types of dementia, including chronic traumatic encephalopathy, CTE, as well as Alzheimer's disease. So, what do we see in Alzheimer's disease? So the cardinal feature of Alzheimer's disease, the thing that we see the most often is memory impairment. That tends to be the thing we see most early. That tends to be the most prominent feature. And when we're talking about memory impairment, we're especially talking about declarative and episodic memory, meaning memory of, of events, of things that they're told, things like that. And specifically, it's sort of things, it's some memory that's being encoded in areas of the hippocampus. So sort of memory in terms of minutes to days. People with Alzheimer's frequently, they can easily, at least early on in the course of the disease, they can easily remember, where they grew up, their parents' names, the street they grew up on, their old house, things like that. But they, they might not remember what they had for breakfast that morning or for dinner the night before, or, that their spouse told them to go out and buy milk on the way home, things like that. So that tends to be the type of memory impairment that we see most prominently early on in the course of illness. Obviously, as the illness proceeds, the memory impairment gets more profound and affects more domains of memory. Other things you can see in Alzheimer's disease are executive dysfunction, which are, problems with planning things out, with organizing themselves, things of that nature. You can see visuospatial impairment, difficulty judging where things are in space, understanding the spatial relationship between objects, things like that. Especially as the disease progresses, you can frequently see behavioral symptoms, agitation, sometimes aggression, sometimes, not recognizing caregivers, becoming agitated with routine tasks such as bathing or getting dressed. And the other thing about Alzheimer's is it's a progressive disease. These plaques, these tangles spread throughout the brain, become more prominent. And, this is a disease that does eventually result in death, either directly or indirectly. But, this is a progressive illness over time. Sometimes progresses more quickly or more slowly in the individual, but it is always progressive. So how do we diagnose Alzheimer's? The most important thing in diagnosing Alzheimer's, and really the way Alzheimer's is diagnosed now at this point in 2020, is mainly by clinical history and assessment. This is the most important thing. So, the patient coming in, talking with me, they're telling me about their concerns with memory, and especially important with some of these patients is, their partners, their spouses, their children, people who know them well, telling me about the problems with memory, because another issue with Alzheimer's is frequently the patients, especially as the condition goes on, don't recognize how much they're impaired, which is obviously frustrating for the caregivers. So, having someone else there to discuss the concerns is always very important. And then, usually in the office, I'll at least do a brief cognitive screening, sort of asking questions to assess the patient's memory, assess their cognitive function, their orientation, their organizational skills, things like that, which, can be as simple as asking them questions like, so what did you have for breakfast this morning? What did you have for dinner last night? Oh, you read the newspaper. What was an interesting article you read? All the way up to, okay, remember these 5 words, and I'll ask you for them again later, and things like that. Brain imaging is important in the diagnosis of Alzheimer's. Typically, in any patient, before I diagnose them with Alzheimer's, I'll want to get an MRI or a CAT scan just to make sure that there's no other structural problem that's accounting for these memory problems, that they're not having, that they didn't have a big stroke, that they're not having bleeding in the brain, that there's nothing else going on. The brain imaging also can indirectly give us some clues about whether there is Alzheimer's disease or another type of dementia. Laboratory testing, meaning tests of the blood, of the urine, things like that. That's less done to directly diagnose Alzheimer's, and again, more done to rule out other conditions like vitamin deficiencies or thyroid deficiencies, things like that, that can also affect the memory, and that, should be treated directly rather than treating the dementia. In rare cases, we can do sort of advanced or experimental testing. There are advanced imaging techniques like SPECT scans and PET scans that look a little bit more directly, at what areas of the brain are using more or less glucose or more or less oxygen, or looking directly to see, are we seeing deposits of amyloid in the brain based on using molecules that bind to that, and seeing where in the brain that amyloid is deposited. And then there's also, you can do spinal fluid testing via a spinal tap or a lumbar puncture to look at things like levels of amyloid proteins and levels of tau in the spinal fluid that can give some information. At this point, those diagnostic tests are mainly used, in Alzheimer's specialty centers, or in cases where there's significant doubt or confusion about the diagnosis, people who are especially young or have an especially atypical presentation. For most routine cases, at least I personally do not order these advanced imaging techniques. Moving on to another type of dementia, vascular dementia. That's the second most common cause of dementia, which is caused by problems with blood flow in the brain, which, you know, can be sort of directly after a stroke, depending on what areas of the brain the stroke affects that didn't get enough blood flow during the stroke. That can certainly cause issues with the thinking or the memory, depending on where those are, typically in patients with post-stroke dementia, as opposed to sort of the more steady decline you see in Alzheimer's disease. You'll see sort of a stepwise decline. You know, people will get a stroke, they'll have a problem, they'll sort of stay at that level, then they might have another stroke, stay at another level. Or there can be vascular dementia without stroke. You know, some people, when we do those MRIs, even though they don't tell me about a history of a stroke, when I do the MRI, we'll see evidence that they might have had, you know, what's called silent strokes, or I actually came across this term in doing research for this topic. I saw the term covert strokes, which I actually like a little bit better because, you know, especially if the patient is presenting with dementia, the stroke isn't really silent, it's causing a problem, but, you know, it's not sort of the type of stroke that we expect to see where people come in, you know, with weakness or a facial droop or things like that. More than, you know, I'll sort of with these other dementias sort of talk about things that can differentiate them from Alzheimer's. So in vascular dementia, especially early on, more than the episodic memory, you'll see issues more with the executive function and with the processing speed. So, you know, people with vascular dementia, you know, if I give them sort of that list of 3 words to remember, will tend to do better than someone with Alzheimer's disease, but might have some more issues with tasks that involve executive function or speed of processing information. Third type of dementia is dementia with Lewy bodies, which is felt to be the 3rd most common cause of dementia. You know, this is another type of neurodegenerative dementia involving breakdown of certain types of nerve cells. This time, the types of, this is caused by what we call Lewy bodies, hence dementia with Lewy bodies. Those are made up of a protein called alpha-synuclein. And those areas of abnormally aggregated alpha-synuclein sort of spread throughout the brain. They tend to start in the brain stem, areas like that, and then spread more widely in the brain. Interestingly, this is the same protein alpha-synuclein that's seen in Parkinson's disease, and that, you know, and depending on what areas of the brain those deposits tend to aggregate in some people it can present as Parkinson's disease, and some people as dementia with Lewy bodies. And I'll speak a little bit more about that moving forward. Here again is sort of an autopsy slide of a patient who passed away from dementia with Lewy bodies. This is looking at the brain. These sort of triangular cells are the nerve cells. And then if you look, this is looking at a special stain that binds to that alpha-synuclein protein. And you can see the areas where that stain is sort of binding and caught, and you can see the Lewy bodies lighting up there. So what does dementia with Lewy bodies look like? One of the hallmark signs of dementia with Lewy bodies is cognitive fluctuation, meaning, you know, sort of very rapid changes in the cognition, in the thinking, and even in the level of consciousness. So people with dementia with Lewy bodies, you know, they'll sort of be alert, and then suddenly, you know, they'll be sort of not responding, staring at a wall, very drowsy suddenly, things like that. You know, every type of dementia does have some degree of fluctuation, but, you know, with dementia with Lewy bodies, it tends to be a little bit more pronounced, especially early on, and it tends to be more prominent. Visual hallucinations are another very prominent part of dementia with Lewy bodies. These can be sort of disturbing hallucinations, things like that. Another feature that can even predate the true memory issues or thinking issues with dementia with Lewy bodies is called REM sleep behavior disorder. So what that basically is people will act out their dreams, dream enactment behaviors. So normally when we're having dreams, when we're in REM sleep, the normal function of the brain sort of is such that, you know, even though you're sort of dreaming about, you know, running around, screaming, you know, fighting off someone attacking you, the body sort of stays still. But in people with dementia with Lewy bodies, or even before that, in people who are destined to have dementia with Lewy bodies, they can lose that ability to sort of silence the body's activity during dreams. And these people will, their spouse or partner will say, they were acting out their dreams, flailing their arms, kicking, hitting if they were dreaming of running away from someone. And, so they'll sort of kick, hit, their partner will wake them up being like, what's going on? And they'll say, oh, I was dreaming, I was running, I was dreaming. Someone was attacking you, things like that. So that, is a very sort of prominent sign of dementia with Lewy bodies and other Parkinsonian syndromes. As I said, dementia with Lewy bodies has the same brain pathology as Parkinson's disease. And so you can get some manifestations of Parkinsonism, meaning slowed movements, difficulty walking, difficulty with facial expressions, things like that. Tremor tends to be a little bit less prominent in dementia with Lewy bodies than in Parkinson's disease proper, but certainly can happen. And overall, the motor manifestations tend to be a little bit less severe in dementia with Lewy bodies. Other things you can see in dementia with Lewy bodies: falls, loss of consciousness, autonomic dysfunction, meaning problems maintaining a blood pressure, which, again, can lead to things like passing out. Along with the visual hallucinations, you can get delusional thinking, especially delusions of, people trying to harm them, delusions that their spouse is being unfaithful to them, things of that nature. And that can also be a major source of stress and anxiety for the patient, as well as for the family and caregivers. In sort of discussing dementia with Lewy bodies, I'll also discuss Parkinson's disease dementia. People with Parkinson's disease can also have dementia or memory problems associated with the Parkinson's disease. Again, these tend to be issues with executive and visuospatial dysfunction, hallucinations, delusions, similar to things that you see in dementia with Lewy bodies. And again, as I said, when you look at the brains of these patients, they sort of have the same pathological finding, those Lewy bodies, just in different areas of the brain. Sort of as a neurologist, we sort of have what we call the 1-year rule for whether someone has Parkinson's disease dementia or dementia with Lewy bodies. And that's if the patient had motor symptoms of Parkinson's disease for at least a year before the thinking and memory issues developed, they're felt to have Parkinson's disease dementia. Otherwise, if the memory problems develop first or at the same time as the motor problems, they have dementia with Lewy bodies. I'll just speak for a moment about frontotemporal dementia. They're another more rare type of dementia, but interestingly, these are patients, especially with behavioral variant frontotemporal dementia, that early on present less with issues with memory and more with issues with personality and behavior. So these are people who develop issues relating to other people, people who, were always sort of very organized and reserved, who all of a sudden become very aggressive, very agitated, they lose their empathy, they can't understand why other people don't see things their way. They can develop compulsive behaviors like compulsively washing, compulsive religious behaviors. They can also develop hyperarousal, meaning changes in taste. These are patients who, will all of a sudden start eating, very sugary foods, won't be able to stop themselves from eating, things of that nature. And then there's also primary progressive aphasia, which is a type of dementia mainly affecting language, either spoken language or understanding of language before the effects on memory. And again, I think I sort of alluded to this before, these differences are especially prominent early on in the course of these dementias. As people advance in dementias, someone with Alzheimer's, in addition to the memory problems, can develop issues with social understanding, can develop issues with language. So, especially if I'm meeting someone who's sort of further on in the course of their dementia, it's important for me to understand how these things started to help try to untangle the course of the dementia and the diagnosis that this patient has. I'll just say for a moment, there is definitely mixed dementia types, which is basically somebody with different types of conditions that are all contributing to their dementia or their issues with thinking. Frequently, vascular dementia can coexist with Alzheimer's dementia. You know, as people get older, in addition to the risk for Alzheimer's, the risk for things like stroke and cerebrovascular disease also increase. So there's definitely a relationship there, which probably gets to the thing I spoke about earlier in terms of the benefit of exercise and controlling vascular risk factors in terms of reducing dementia. Frequently, dementia with Lewy bodies and Alzheimer's can also coexist. So I do want to speak about the treatment of dementia, you know, and I'm sort of going to speak about the treatment of dementia as a whole. You know, the medications that I'm going to speak about were definitely originally created for Alzheimer's. I'll speak a little bit about applying them to other dementias, but at least right now in 2020, the treatments that we have for memory problems in dementia are sort of blunt instruments in the sense that, you know, they don't necessarily treat the individual pathologies of these conditions. They sort of help with memory or thinking more broadly. So one class of medications that's used for memory problems in dementia, they're called the cholinesterase inhibitors. They prevent the breakdown of a protein called acetylcholine in the brain. Acetylcholine is a neurotransmitter that allows for the communication between cells. And there have been studies showing that in Alzheimer's and in other types of dementia that the brain loses the cells that produce acetylcholine. And by increasing the levels of acetylcholine, you can have improvement in cognition, as well as some of the psychiatric symptoms and in some cases the activities of daily living. You know, these are medications that are designed to delay or slow symptom worsening. I'm not necessarily expecting when I start a cholinesterase inhibitor for a patient, you know, with dementia to suddenly have, you know, a reversal of their condition, but, you know, it can at least slow down the process. Side effects of cholinesterase inhibitors, there can be some gastrointestinal effects, including nausea, diarrhea, things like that. There can be some cardiological effects, slowing down of the heart rate or lowering of the blood pressure, which needs to be monitored for. With some of these, there can be some sleep disturbance or very vivid, disturbing dreams, which is something else to look out for if people take these and, you know, as opposed to getting better, sort of get more agitated or more confused, that may be at play as well. So, you know, there are 3 of these that are approved in the United States: donepezil, galantamine, and rivastigmine. They're all basically interchangeable in terms of their effects. You know, different neurologists have different favorite ones. I tend to start with donepezil because it tends to be pretty widely available and pretty widely covered. For some patients, I will use rivastigmine because that's available in a patch formulation. So for people who have trouble with oral medications, that can sometimes be useful, or in people who have a lot of GI side effects, that can be useful. So, you know, as I said, there's some evidence for these in dementias that are not Alzheimer's. Dementia with Lewy bodies, again, there seems to be a prominent deficit in acetylcholine, possibly even more than in Alzheimer's disease, so they're definitely useful there. In vascular dementia, their cholinesterase inhibitors are also felt to be likely beneficial, which at least in some part may be due to some of these patients having some Alzheimer's pathology as well. I will say, you know, cholinesterase inhibitors in large studies don't seem to have a benefit in mild cognitive impairment. So, you know, these people who say, you know, well, I'm having a little bit of memory problems, I'm just going to take this medication to be safe. The studies don't show that it really helps in that situation. It also doesn't really seem to have much benefit in the frontotemporal dementias. I'll also speak about Mementine, which is the other FDA-approved medication. It blocks a receptor for a neurotransmitter called NMDA. And NMDA receptors, when they're activated too much, they can actually be toxic to the nerve cells. And so by decreasing the overactivation of these NMDA receptors, Mementine may help to preserve the existing nerve cells. The evidence of benefit for this is in moderate to severe Alzheimer's disease. Again, doesn't show benefit in mild cognitive impairment, doesn't seem to show much benefit in mild Alzheimer's disease either. Usually tolerated pretty well. The most common side effect is dizziness, and it's frequently used in combination with the cholinesterase inhibitors, and there actually is a pill called Namzaric that's sort of a combination of donepezil and Mementine. I do sort of want to talk about horizon. I'll sort of take a moment to speak about upcoming things in the treatment of dementia, or at least possibly upcoming things in the treatment of dementia. So in Alzheimer's disease, I think I spoke about, the issues with the deposits of beta amyloid and tau leading to nerve cell breakdown. What's being increasingly understood in Alzheimer's disease is that, the deposition of these proteins, the breakdown of the nerve cells is happening years and possibly even decades before the patient comes to us with memory problems. So, this is sort of a chart that would be familiar to many neurologists looking at it, but just sort of looking, so if this line is when the patient is diagnosed with dementia, years before is when they're accumulating the amyloid, and by the time they're diagnosed with dementia, the amyloid is pretty much there. Some of the cell breakdown hasn't happened yet. You haven't lost all of the brain structure yet, but even the brain structural loss is happening before the diagnosis of dementia occurs, and really before the patient even knows that they have memory problems. And this is where conditions like those genetic Alzheimer's disease conditions become interesting, because, in those patients that have mutations that sort of tell us, this is a patient that as they get older is going to have dementia, definitely, that gives us a chance to look at these patients years or decades before, because, we sort of know what the end point will be, and we can really see, if we give these treatments much earlier on, what the benefits will be. And again, as I said, all the treatments we have right now for dementias are sort of blunt instruments. It's a hammer to hammer in the nail of dementia. But what if we could actually do things to target the individual types of dementia, like a Phillips head screwdriver or a flathead screwdriver, for instance. So, so people are looking at sort of treating more individually the problems for each individual dementia. So in Alzheimer's, as I said, one of the main issues that we're looking at is the accumulation of amyloid beta. So there's a drug that has been tested in Alzheimer's disease called Agiocanumab, which is a bit of a mouthful, but basically that's an antibody that's been created that binds to beta amyloid and stops the beta amyloid from accumulating and helps to break down the accumulated beta amyloid. So, this is going to the problem itself in Alzheimer's disease. This is a medication that's given IV, that's given monthly. And this is a medication that was tried in 2 big clinical trials called Emerge and Engage. And they looked at people who have either mild cognitive impairment due to Alzheimer's or mild Alzheimer's disease. In this study, in this study, as opposed to many other studies of dementia, you need to have some of this advanced imaging. You need to have a PET scan showing that there's amyloid in the brain, because otherwise it probably won't work. So this is sort of where things might change. In a medication like this, you really want to have that advanced imaging. They need to be 50 to 85 years old, the patients. They didn't have any other neurological condition contributing to their cognitive decline. So again, these aren't patients with those mixed dementias. And they were treated either with a placebo medication, with a low dose of this Agiocanumab, or a high dose of this Agiocanumab. And the main endpoint was a clinical dementia rating, which is a rating of, people's cognition, their thinking, and their activities of daily living. And these trials started in September of 2015, and I don't know if anyone was following this. This is sort of an interesting story, but a little over a year ago, there was an interim analysis of these studies where statisticians looked at the sort of early results of this study and saw that, from what they could tell, the medications didn't work. There was no benefit. The placebo people did as well as the people on the drug, so they stopped the trial. Then a couple of months later, the drug company came back and said, wait a second, if you look at this slice of patients, people with Alzheimer's disease who were treated with the higher dose of the medication, there actually was a statistically significant difference between these. A small difference, but a statistically significant difference. And based on those results, they have actually gone to the FDA for approval of this medication. And this medication is under FDA review. And if it is approved, this will be the first drug targeting the molecular mechanisms underpinning Alzheimer's. So this is, that Phillips head screwdriver for the Phillips head screw of Alzheimer's. It looks like we're running a little bit low on time. I'm going to stop speaking now and ask for any questions.
Pam, you want to unmute?
Yes, of course. Are there any questions for Dr. Gottman?
Diane, go ahead.
Hi, quite an informative lecture, Dr. Gottman. My husband was, well, I don't know if he was actually diagnosed, but I noticed a change in his mental status 2 years ago at age 90. He is 92 now. And we did the neurological route, and I wasn't really very satisfied. And since most of my husband's situations were behavioral, we are seeing a geriatric psychiatrist. But what I wanted to ask you is, as you went through the different types of dementia, I found a little bit of everything. I've never labeled him with a type, nor has he been professionally labeled. But yet I find a little bit of frontotemporal. I find a little bit of Lewy body.
So, again, as I said, that is sort of a little bit of the trouble with dementia and with these diagnoses, and again, especially as things move forward, a patient with advanced Alzheimer's disease looks a lot like a patient with advanced dementia with Lewy bodies, or a patient with advanced vascular dementia. That's sort of why I said, some of it goes back to, well, what did they start with? Is it a patient who, sort of started with problems with memory, or is it a patient who, their memory was perfect, but, sort of couldn't relate to people, or someone who, whose memory was okay, but started to have hallucinations or delusions that were atypical for them, things like that.
Right.
And I did also want to take a moment to acknowledge something that you said about behavioral treatments. That's definitely an important aspect of the treatment of dementia. And, we work closely with geriatric psychologists and psychiatrists as well, because, a lot of the these medications, as I said, they do to some degree help slow cognitive decline, but they don't stop everything. And, many patients do have issues in terms of, depression, anxiety, things of that nature. And, those can be treated, either with supportive therapy, counseling, involvement of the families, or in some cases with, antidepressant medications or anti-anxiety medications, or even just, groups and, interactions with people and, dementia day programs, things of that nature. So, I don't, again, I sort of focused on the medications because as a neurologist, that's frequently what people are coming to me for. But, definitely, as you said, those caregiving aspects are a vital part of the treatment of dementia.
And what I would also like to know is, how important is it in this stage of the game for me to know exactly what type of dementia he has?
Again, I think that gets a little bit to my hammers and nails analogy. At this point, most dementias are treated similarly in terms of, things like the cholinesterase inhibitors, and in some cases, the Mementine. Again, if someone comes to me and they're 90 and they're having memory problems, I sort of treat it as Alzheimer's until proven otherwise, again, because the vast majority of dementias, especially in the oldest old, are Alzheimer's dementia. And, again, the treatments I would use for Alzheimer's dementia are frequently broadly useful in other types of dementia. I think the utility of finding out what type of dementia may lie in something like, well, if we did an MRI and saw evidence of strokes, things of that nature, well, then that would get to, well, we need to figure out what's causing his strokes, control those vascular risk factors, things of that nature, that would be treated very differently. Or, if we had a strong suspicion for something like dementia with Lewy bodies, then we might be more cautious about using medications that could lower the blood pressure, or that, or medications like antipsychotics, which those patients with dementia with Lewy bodies can be especially sensitive to.
Thank you.
Sure.
I have a question.
Yes. Hi.
Hi, Dr. Guttman. That was really good. The new, I guess, FDA process for the new possible medication, you said that it's showing some like significant.
So again, I want to be careful with what I said. It showed a statistically significant improvement in some markers of dementia.
So my question is, improvement with what? Is it memory recall?
So, so again, they used sort of a composite endpoint called the clinical dementia rating. So, it's sort of looking at, sort of a composite of, things like, the memory and recall, the activities of daily living, things like things of that, sort of a composite endpoint, which many of these studies do look at, and again, I don't want to sort of I use the word significant, but I want to sort of emphasize statistically significant, which, again, as one of my colleagues here once said, well, if they did the study and they said this, and at first they said the study wasn't useful, and then they had to have statisticians come in and take an extra look at, a very small portion of these patients to tell us the medication works.
Right.
How much is it really working? And I think, that is a little bit of a question about drug development and drug approval. That's a little bit broader than our discussion here, but, I do think that is an important question, and again, I think that drug, potentially has huge implications for how we treat dementia and expenses for patients with dementia, because, again, in order to put someone on this drug, again, as I said, I routinely don't do these sort of PET scans or advanced imaging, but if I was going to put someone on a drug that targets beta amyloid, I would start to do PET scans on these people before starting that medication, and that has an expense. This is an IV medication given every month. That has an expense. And so, it's really going to come down to, cost of medication versus benefit, which, are things that the FDA looks at, things that other government agencies look at in terms of drug pricing and things of that nature. I mean, as an MS doctor, I've sort of thought about these things in an MS perspective for a lot of these drugs as well. But, this drug potentially has a huge impact on the finances of medicine and really on Medicare's finances, especially given that, the US population is only getting older and the incidence of these conditions is only going to get higher.
I have a question.
Sure.
I don't know if you can hear me.
Yes.
Hi. My mom will be 92 in February, and there are different symptoms going on. I'll jump to my question first, and then I'll give you more information about it. My question ultimately is going to be, is there any benefit in having her evaluated at this point to be put on any medication? And now I'll describe what I'm seeing. My mother has had a hand tremor for many, many years, but now I'm noticing when she walks around her apartment, she's shuffling. Her personality is fine. She's very even-tempered. She does get very tired. She needs to take a lot of naps. I'm finding that sometimes if I'm telling, my mother was very highly educated. She was very, very smart. So there should be cognitive reserve there. So I'm going to qualify that. Sometimes when I'm telling her a story, she's great. And sometimes when I'm telling her something, she can't follow the pattern of the story. She can't follow this. She can't get onto it sequentially. Sometimes she doesn't know what day it is. Sometimes she's not sure which daughter has which grandchild. So the question is there any point in having her evaluated? Is there any benefit to medication at this point? I mean, she does have heart medication. She does have diabetes medication. So I take care of all her medical issues. So it's on my head. It's my responsibility. So the question is, am I being remiss by not having her evaluated to be put on any medication, or is there really not much that can be done?
Again, I think that, some of that is a little bit of judgment, and again, I think some of it also depends on how much it's bothersome to her, bothersome to you, how much it's interfering with things. I definitely, again, I always think that, if there's a concern there, if it's something significant, something that you're noticing daily, that it's worth at least getting looked at and, again, getting evaluated by a professional to see, is this normal aging? Is this something that we don't expect? I'm going to share my screen for another second and use this as sort of a little bit of an ad break to say, this is where I am most of the time at NYU Winthrop Neuroscience, which is now located at our brand new facility at NYU Langone Ambulatory Care in East Meadow, where we have a brand new facility with many neurologists, many of which are experienced in the care of dementia, Alzheimer's disease, as well as all other types of neurological conditions. So, again, I'm sure, myself or one of the other neurologists, I'm sure would be happy to examine your mother and, and see, what do we think? Do we think this is something pathological? Do we think
because sometimes I play a little game with myself and I say, okay, how would I compare her affect and her demeanor to how it was even a year ago? I see vast changes.
Yeah. And again, I think if there are changes, if you're noticing a difference, that, I do think that it is worth getting evaluated.
Thank you, doctor.
Sure.
She could see you if I wanted her to?
Sure. Just call the office and say, you're interested in seeing Dr. Gottman.
Okay. Thank you, doctor.
Sure. Any other questions?
No.
Oh, I'm seeing something.
Thank you so much for everything. I really appreciate it.
Doctor, maybe you could stop the screen share. Okay, thank you. Any other questions?
Kelly was raising her hand. Kelly?
Hi everybody. Hi, doctor. I do have a quick question. Being that we work with many, all our families are, obviously with people with dementia. One of the questions I get a lot is, they can handle a lot of it except the outbursts, like the inappropriate behaviors or the anger, the frustration, that kind of stuff. What I don't know if there's Risperdal or Haldol, like, those types of things were used to be used. I don't know if they still are, but what do you typically treat for or use?
Yeah, so that, that gets to be a complicated issue, things like treating, outbursts and agitation and things like that. And, I think the first step with something like that is sort of taking a step back and trying to see, well, what's causing those outbursts and agitation? Is it that they're uncomfortable or in pain, or, they have a fever, or, and again, especially as the dementia gets more advanced, it may be more difficult for them to express those things, at least in ways we would find appropriate, or, is this somebody who, for whatever reason, because of the dementia, finds it uncomfortable or frightening to, take a shower or go to the bathroom or, be left alone, things like that, so I think first of all, trying to evaluate, what's causing the condition, and are there behavioral things we can do in terms of, reassurance, sort of changing the time of day we're doing things or the time of week we're doing things like that can help. Then sort of the second level becomes, well, are there other psychological or psychiatric things happening, in terms of, is this someone that's depressed, that's anxious, and would they benefit from something like an antidepressant or an anti-anxiety medication at a low dose? Is it that, their sleep isn't good and, they they might need some help with sleep at night with something gentle like melatonin, something like that. You know, as far as sort of, you had mentioned a few of the antipsychotic medications like Risperdal, Seroquel, things of that nature, you know, those, I truly consider those medications of last resort. You know, those are medications, you know, they will frequently calm patients down, you know, they will frequently, you know, help them go to sleep, things like that. But, you know, there are definite risks to those medications. You know, they have an FDA black box warning on them saying that they can increase the risk of death in patients with dementia who are treated with them, which again, doesn't mean they're never to be used. And I never use them, you know, in patients who, you know, are at risk for hurting themselves, hurting others because of agitation, because of aggression. You know, sometimes we're left with no choice but to use those medications. But I think, you know, those sort of behavioral measures, including, you know, reassurance and, you know, touch and just sort of reframing the situation, things like that, you know, that's sort of first line. You know, other psychiatric medications for depression and anxiety would be second line, and sort of even anti-dementia medications, as I sort of alluded to, can sometimes help with some of these issues with agitation or these other.
What do you commonly prescribe for the for the depression or the anxiety?
It depends a little bit on the patient. You know, I sort of try to use medications whose side effects, you know, might be beneficial. So for example, in patients who, you know, are depressed and have a lot of issues with sleep and appetite, there's a medication called Mirtazapine that, you know, sort of a couple of its side effects are promoting sleep and promoting weight gain and appetite. So, you know, in someone like that, I might prescribe that. You know, I use, you know, also I just use a lot of the other antidepressants like sertraline, paroxetine. You know, again, I use sort of all different ones depending on the patient. You know, and again, sometimes some of these people have been started on other antidepressants by their primary doctor or by a psychiatrist or things like that. You know, and conversely, I should also say, you know, in people that are having sort of outbursts that are atypical for them, things like that, we need to make sure that, you know, it wasn't a medication added on that's sort of tipping the balance in a negative way and having side effects, because, you know, many medications used for all different things, you know, you start someone on gabapentin for neuropathic pain from diabetes, and suddenly they can get more confused, you know, and so that, you know, those are also things we need to take into account, you know, in addition to adding medications, whether it's worth taking medications away. So I don't want to say that adding medicine is always the answer.
Right. Thank you so much.
Sure.
Any other questions? Nobody?
No.
Okay, well, I want to thank Dr. Guttman for a really wonderful, informative presentation. This has been really, really wonderful. Thank you so much.
Yeah, and thank you all. Thank you.
Thank you.
And thank you, Gloria, for inviting me. Thank you, Lucia, for helping to put this all together. And thank you, all of you, for your attention, for participating. You know, I really enjoyed it. And, you know, again, I'm happy, and my colleagues are definitely happy to see any of you with more individual concerns about, you know, whether it's yourself, your family member, other loved ones, friends, things like that. But, you know, I hope everyone has a great weekend and stays safe.
Before you leave, Dr. Guttman, can you just put your information in the chat for a moment? And so, or Lucia, if you could do that, somebody, so that way, if people want the information,
That's a good idea.
they can certainly get a hold
Sure.
of it.
So yeah, let me just sort of
Yeah, if you, anybody that wants the information, it will
I'll
be in
just
the
type
chat.
out the information.
Yeah,
for
just
the,
type it out if
for
that's
the
not, yeah, just
facility.
the phone number to the office or the email, whatever would work.
Does that ambulatory center have all the equipment for MRIs and CAT scans? And
We have MRIs on site. We have MRI on site. We don't have a CAT scan on site, but we certainly have access to a CAT scan if we need it. You know, we have access to EEGs. We can do blood work on site. We also have physical therapy and orthopedics on site if you need that.
Me too.
And if you want, I could put my email and phone number in there as well. So if anyone wants to reach out to me,
That's
I could
great,
always
Lucia.
transfer you or connect anybody.
Yeah, that would be great, Lucia. If you could do
Wonderful.
that, that would be
No
very
problem.
helpful.
So I just put it in the chat, but the number is 516-324-7500.
Excellent.
Perfect.
Thank you
Thank
so
you
much, Dr.
so
Guttman. Much
much.
appreciated.
Sure.
It's a great resource, everybody. You know, we get calls all the time looking for dementia specialists, and can't say on the South Shore that we've been as fortunate as to have a bunch of really good. So, you know, this is pretty good.
We're
It's not
sort
too
of
far.
middle shore here.
Yeah, it's North Shore, but not so far into the North Shore is the way I
No,
look at
it's
it.
more central.
Exactly. So we're not going so far north, which is really
I mean,
nice.
I live on the South Shore and I get here every day. So
See, you can do it. That
Right.
means they can do it. That's a good,
Thank you.
that's a good way to look at it. All right, everyone. Thanks so
All
much
right.
for coming. We're so glad
Thank
that you were able to
so
come on.
much.
Be on the lookout for more of these kind of presentations. We're trying to make them monthly if we can. So kind of be on the lookout. We've got your emails. We will send them out. And remember, Pam has lots of also programs for individuals with dementia. Her social adult day program is now 3 days a week. Early stage is Tuesdays and Thursdays. Wednesdays is moderate. They're pretty much full day programs. And so certainly if you have any questions, reach out to Pam for more information. All right, everybody, take care.
Thank you, everyone.
Have a good weekend. Thanks.
Thank you.
great weekend.
Bye,
Bye,
everyone.
Lucia.
Dr.
Take care of
Guttman.
yourself. Thanks, Dr. Guttman.
Bye.
Thank you. Thank you so much.